Alliance, and welcome to the 6th session of the Adolescent HIV Prevention Echo. Just going to pull up my slides here. Oops. Sharing. Oh, I'm not sharing. Yeah. Second. Give me 1 second. Intro slide. Okay, welcome everyone. Okay, so just a reminder, as you join, please enter your name and your organization in the chat box so we can keep track of attendance. So for our session today, this is the first part of a two-part session. So one of our faculty, Justin Smith, is going to be presenting on examining the social determinants of HIV risk in LGBTQ adolescents. And again, this is the part one of a two-part series. Justin is a behavioral scientist at the Rollins School of Public Health at Emory University. He's also the director of the Campaign to End AIDS at the Positive Impact Health Centers in Atlanta, Georgia. We're also going to have two case presentations this afternoon. The first one will be from Erin O'Donoghue, who is with the Rush School-Based Health Center at Orr High School in Chicago, Illinois. And then we're going to hear from Jidleen Cherilus, who is with the Jesse Trice Community Health System in Miami, Florida. So just a reminder, you will receive an email from the email address on the page regarding CEs from APHA. Presentation slides and recording will be posted to Moodle by tomorrow. And just a reminder, as I said earlier, that this is part one of a two-part content module. So you're only allowed to miss one live session in order to receive CEs. So if you miss one of these live sessions, you have 1 week to watch the recording on Moodle and complete a reflection on the forum in order to get your CEs. So I'm going to pass it off to Justin now.
All right, well, thank you so much, Suzanne, for that lovely introduction, and I'll go ahead and start. Okay, why is this not working? Sure. Okay. Can y'all see my slides now?
Yes.
All right, perfect. All right, so as Suzanne said, this is kind of the first of two sessions that we'll be doing that are examining the social determinants of HIV among adolescent LGBTQ folks. And so today's talk will primarily focus on a couple of conceptual frameworks, and then we'll get more into sort of resilience and kind of action steps in next month's module. So this is really just to try to ground us in some common language and to give us a foundation for talking about the social determinants of health. So I always like to begin my presentations with the acknowledgments. I had many thought partners as I was thinking about kind of putting together these slides. So I wanted to just shout out to some of the folks here who were helpful in getting me ready for this talk this afternoon. So just to give you a roadmap of where I'd like to go in our webinar this afternoon. So first, I think it's important for us to just get a definition of what do we mean by SDOH. It's something that gets tossed around a lot in sort of the public health space. So I want to just make sure that we have a common language for talking about it. The bulk of the presentation will center on three things. So the first piece is a framework that many of you are probably already familiar with, which is intersectionality. The second framework that I'll go into is Syndemics. And the last part of the presentation will focus on a case study, and this is based on a paper that I wrote with some of the folks in the acknowledgement slide that looked at kind of networks as a social determinant of HIV among young Black MSM. And so that will be the last piece of this morning's, this afternoon's presentation. And of course, as we go along, if you have questions for me, if things pop up that you want to talk about, please, chat that in. I will be sure to try to respond to questions as we go along. So my hope is that by the end of our time this afternoon, you'll be able to describe how you can apply these two frameworks of intersectionality and syndemics, specifically the understanding HIV among LGBTQ youth. And then I'd like for you to also be able to describe how networks can serve as a determinant of HIV among LGBTQ youth. So if those two things are accomplished, then I know I will have done the work that is before me today. So when we talk about social determinants of health, again, I think this has become somewhat of a buzzword within the public health space, but I wanted us to kind of ground ourselves in a specific definition. And so this definition comes from the CDC, which in turn drew this definition from the WHO, the World Health Organization. And so what this definition says is that the social determinants of health are the circumstances in which people are born, grow up, live, work, and age. And this also includes the systems in place to offer healthcare and services to a community. And that these circumstances are in turn shaped by a wider set of forces, including economics, social policies, and politics. And I think that this is a pretty nice overarching kind of grounding of what we mean by this, but I think it also gives you an appreciation for kind of how broad and far-reaching factors can be when we're talking about social determinants of health. And so, but I just wanted to lift that up as a place to start. And certainly as we go through the talk, we can kind of offer refinements, revisions, or additions to this working definition of SDOH. So I wanted to show you a couple of maps because I think they beautifully illustrate how SDOH concepts intersect with HIV. And I'm going to go through these slides quickly, purposefully, because I want you to actually see sort of the visual map. This first map, again, comes from CDC HIV surveillance data. And what it shows is new HIV diagnoses from 2016. And this is of kind of all races, ethnicities, men and women, all transmission categories, and all folks 13 years and older. And basically what I want you to take away from this slide is you'll see that the darker states are the places where they had greater HIV diagnoses. This next map is that same kind of data, but specifically looking about within kind of MSM or gay and bisexual male HIV transmissions. And again, you'll notice that some of the same states are kind of in that darker hue. So this map is looking at poverty rates. And again, this is taken from 2015. I didn't like that I wasn't able to find data from the same year for this, but these things don't really shift much year to year. What you'll also see is that kind of in the places where we see the highest rates of poverty, you know, it also looks very similar to what we saw in terms of the HIV maps that I showed previously. You'll see sort of a similar trend when we look at the percentage of the population aged 25 and older who do not have a high school diploma. You'll sort of see some of the same areas that we saw that were darkest in the hues in the previous slide, also being represented in sort of the darkest hues, representing the greatest proportion of the population who do not have a high school diploma here. And then you can also see in terms of housing, we also see sort of a similar patterning of where we see kind of making housing use it, which is a measure of kind of housing market strength within a given zip code and county. And you can see that this also tracks what we saw with respect to HIV. So why is this important? I think, the reason I wanted to show these maps is I wanted to be able to illustrate that when we talk about the social determinants of health, we think about things such as education, we think about economic status, we think about access to housing. And how even though the health outcome we're most interested in talking about is HIV among LGBTQ youth in our conversation, it's important to note that these broader forces have kind of a similar patterning, and that there is a relationship between sort of these broader social factors and what we see in HIV rates among LGBTQ youth. So I want to shift gears a little bit and move into a conversation about intersectionality. I know better than to try to show live streaming video in a webinar. So I'll just lift up the example of a television show that's on the channel FX, which is called Pose. In Pose, if you're not familiar with the show, it's really a fantastic piece of television, noteworthy primarily because it's one of the first television shows to have not just one, but multiple trans women of color in leading roles. It also has a lot of conversation in it about HIV and specifically thinking about HIV in kind of the early parts of the epidemic. But I put this, I wanted to show a clip, but again, you can watch it later, or if you've seen the show, you kind of know where I'm going with this. But I think what the show beautifully illustrates in its really complex, nuanced characters is it really embodies what we talk about and what we mean by intersectionality, where we think about kind of what does it mean to be a trans woman of color who's living in a lower SES neighborhood, who's also living with HIV, thinking about kind of all the multiple identities that the characters in the show hold, and how that actually ends up kind of patterning, their experiences of health. So again, I lift this up as some homework for you all that have not seen the show to take a look at least at the first episode. I think it's a great examination of kind of the lived experience of queer and trans folks and trans youth specifically. So take a look at it, and I think you'll find it to be kind of an important piece of cultural history, and I think it's a good way to try to understand the dynamics that exist within this community. So to think about kind of a more textbook definition of intersectionality, and this is, it's used primarily kind of in a theoretical sense, but I think it really does have some really important practical application. And so it's a way of understanding how multiple social identities such as race, gender, sexual orientation, socioeconomic status, and disability intersect at the micro level of individual experience to reflect these interlocking systems of privilege and oppression. So thinking about things such as racism, sexism, heterosexism, classism, what have you, at this broader overarching macro social structural level. And this is a definition that comes from Lisa Boleg, who was really central in helping bring this concept into the public health space. And this is just another definition of it. I'm not going to read this one, and this is coming from Patricia Hill Collins, who's actually one of the mothers of this definition and this way of thinking. And so, what I think is important about this definition that it adds to what was given in the previous definition is it brings in an analysis of power dynamics. And so it really invites us to think about not just the identities that people hold, but how these identities then are intersecting with broader systems of power and privilege. And so that's a really important thing that I think is important for folks to understand about intersectionality and what it means. And then, this last piece, And I think it's about, connecting what we talked about in these previous definitions to a specific focus on health equity and social justice. And so I think, these definitions are really all complementary to one another, and that they kind of add different dimensions to how we think about intersectionality as a concept. Um, and so, I wanted to just ground us in those kind of working definitions, because I think it's important for us to just kind of understand, where this concept comes from. Because again, this is one of these terms similar to social determinants of health that gets kind of talked about and used in lots of ways that are not necessarily always congruent with the original kind of framing of the concepts. So I wanted to just lift up these definitions as a starting point. And so the other piece that I wanted to lift up is that intersectionality as a concept, we talk about it as if it's something that is new. And actually, it's something that has really been around, at least conceptually, for a very long time. And I think in that way, we have to give reverence to Sojourner Truth, who is probably the first person, at least in the United States, who kind of articulated this concept of intersectionality. And this was from her famous Ain't I a Woman speech. And again, thinking about her position as a woman, but specifically as a Black woman, and how she was not afforded sort of the treatment that was given to white women at that time. But claiming that I am a woman as well. And so this is probably the first time in the historical record in the United States that we have kind of this articulation of this concept of intersectionality. So while many people think of this as sort of a new concept, it's been around at least since Sojourner Truth sort of put it into this word. And we think about this kind of in modern times. It's rooted in this Black feminist scholarship. Speaking of particularly Kimberly Crenshaw and Patricia Hill Collins, and these were sociologists and legal scholars, and that's kind of where this thinking comes from. And Crenshaw really came up with this as she was thinking about a legal case that was brought against General Motors. Where it was a group of Black women who worked for General Motors who were alleging that they were discriminated against based on both their race and their gender. And the case actually ended up being dismissed because they brought their claims as Black women. There was no way in the law at that time that they could be sort of seen as both Black and as women at the same time. And so the law actually was not able to kind of understand their position as Black women. And so that's what kind of motivated Crenshaw to kind of articulate this first iteration of what we call modern intersectionality. So again, the core tenets are that, these identities are not independent, but that there are things that are intersecting and multiple. We also, think about this as focusing on folks who are historically marginalized. So that's why, we think about conversations about intersectionality, they often focus on, people from marginalized communities, again, because this comes out of this Black feminist scholarship. And the other piece that I've said before is that it's really about thinking about not just the identities that people hold, but also how these identities intersect with these larger structural forces. To produce, in our case, what we're interested is in health consequences and health disparities. So I think this slide is really helpful in terms of helping us think about how these things work together. And so on the far left, we have these, individual categories. So these are the attributes that individuals have. So thinking about your gender, your race, your sexual orientation, your disability status, your socioeconomic status. So when we think about LGBTQ youth, thinking about not just the gender identity and the sexual orientation of the young people that we're thinking about, but thinking about their race, their ability status, kind of all those things that they may hold as their individual identities. That's kind of the first piece of it, but it doesn't stop there. we also have to acknowledge that there are particular social processes. So, and the processes are the isms. So it's thinking about things like transphobia, heterosexism, classism, racism, all those things that we know kind of are the responses to people who hold those particular identities. And then we know that moving forward, that there are particular structural consequences that happen as a result of those social processes. And so that can result in discrimination, that can result in poverty, that can result in mass incarceration, that can result in police harassment or unemployment. So it's not just thinking about the fact that, you know, we have multiple identities. I think that's kind of something that most people really can understand and grasp, but it's really about taking it up a level and thinking about what are these social processes and the consequences that befall folks because they have been subject to those social processes. So again, bringing this down to why this matters for the young people that you see in your health centers every day. So it's understanding that the young people hold multiple identities. So, you know, they may come to you as a young Latina working class trans woman, right? And so she's going to be all of those things at the same time. And because she holds those identities, she's going to be subject to different types of social processes. So again, thinking about how she may not necessarily just be a victim of transphobia and homophobia, but also racism, right? And thinking about because she's experiencing those types of processes, she may be more vulnerable to negative health consequences, in our case, thinking about how that relates to HIV. So again, thinking about how is this helpful? Why is this useful to the work that you all do in school-based health centers? So I think intersectionality is helpful for kind of two main reasons. I think it's just a powerful way of connecting language and understanding kind of these connections between race, ethnicity, gender, sexual orientation, SES, and how that relates to health outcomes. And again, I think because this has become a term that has been used so frequently within public discourse, we kind of get it, right? You know, but I think it's important to be intentional in our thinking about how we approach our work, working with young people every day. And the other piece that I think is valuable about having kind of a lens that's rooted in intersectionality is that it actually forces those of us that are called to work with young folks and to address, you know, health disparities and social inequities, to think about the world and the experiences of our patients in the very kind of expansive ways that folks actually live their lives. And so I think that just gives us a better tool and a better lens for understanding what people's lived experiences are, because we're thinking in a way that kind of mirrors the way that they move through the world. So, so I think those are, you know, kind of the main things that I think are so important about this as a way of thinking. And again, many of you already are there and are already thinking about the world in these ways, but I think it's just important to name it and to call it out. And so, you know, we've been having sort of another conversation about, you know, how intersectionality shows up. There's been a lot of work thinking about birth outcomes for Black women. And there's a link in here to a really heart-wrenching story about a former colleague of mine at CDC, again, who died after childbirth. And thinking about, you know, how intersectionality shows up, you know, this was a Black woman who had, you know, 2 PhDs and worked at CDC, kind of had all the benefits that you would think would accrue to someone who has high SES due to their education. But then, you know, still had sort of this, you know, the most horrific potential outcome in terms of leading to her death. So thinking about there are ways that these systems don't work for everyone. And so I think that's kind of a way that intersectionality helps us kind of at least make sense of something that actually doesn't make a lot of sense. And so, you know, I want to build on that and bridge into the next conceptual framework I want to lift up, which is the concept of syndemics. So syndemics, and again, this is language that is not unfamiliar to many folks. It's this notion that there can be multiple co-occurring epidemics that additively increase and lead to negative health consequences. So you could think about them as being these mutually reinforcing epidemics that together can lower the health profile of a population than additively more than each would on its own. And this came out of research that was done primarily looking at gay and bisexual and other men who have sex with men in urban areas. So this comes out of the work of Ron Stahl. And one of the things that's I wanted to just star is when we think about, syndemics and the research that's been done on it, so many of the trajectories that are set in kind of these negative pathways are kind of done in early childhood. So there's a lot of focus on kind of early development. And so in this particular articulation of it, it was thought of as kind of emerging from socially produced damages of adolescent male socialization. So when we're thinking about, you as people that work in school-based health centers, you're interacting with folks when they're in these critical periods of adolescence. And so in some ways, folks that work in settings like yours are uniquely positioned to really have an impact, because we know that so many of these negative health outcomes that we see in LGBT folks in adulthood are really set in kind of early childhood and adolescence. And that's kind of where you do your work. So I think this is an important kind of framing to think like we need to do a good job of making sure we're screening for some of these characteristics and these things that are happening in young people's lives, such that we can alter their health trajectory for the long run. So again, just to kind of put some data on the slide here, this was again from Ron Stahl's work. And what they looked at was the co-occurrence of depression, so kind of negative mental health, polydrug use, so using multiple substances, childhood sexual abuse, and partner violence. And those are sort of seen as the syndemic conditions. And what they found was that there was pretty much an additive effect. So if you were someone that, experienced depression, also who was using multiple drugs, who also experienced childhood abuse and partner violence, the more of those adverse conditions you experience, the odds of you being someone who was HIV positive increased. And so there's almost this kind of step function that happened in this data that you can see here. So, and so again, it kind of conceptually makes sense that, if you are subject to kind of more adverse conditions, you're going to increase your risk for HIV. And so that's kind of the take-home message for syndemics, is thinking about the fact that these epidemics can really intersect and worsen one another. So at least in this paper, they were thinking about childhood sexual abuse, depression, substance abuse, and partner violence. And so particularly when you think about kind of the school-based health setting, and you're talking with young people, to think about kind of how you might screen for the occurrence of these types of adverse events. So thinking about childhood trauma, again, these are folks that are still maybe actively experiencing that. So what are things that you can do to make sure that you are capturing when that's happening, and then finding and connecting these young folks to resources that can help them navigate those types of situations. So again, thinking about kind of why this is important for the school-based health setting is that, you are a point of contact for young folks who may be actively experiencing these types of childhood events. So again, thinking about why it's important that there's active screening happening when you have contact with young folks, to make sure that if they are experiencing trauma, that you have resources either on site, or that you built those partnerships with others in your community that can help young people kind of navigate that. Because we know, again, from the data that we have that, adolescence especially is such a critical period for setting folks on to a positive health trajectory in the future. So as we saw, some of the outcomes can be, at least within this particular case, thinking about HIV infection. But one of the things that's important to realize about the social determinants of health, and again, we're focused specifically on HIV in this conversation, but so many of the things that pattern poor health that may lead to HIV may also lead to other types of negative health problems. And so an added benefit for kind of having a screening tool that's rooted kind of in this perspective is that you can help think about, how do I, prevent this young person from acquiring HIV, but how can I also make sure that, they don't get, diabetes or some other type of chronic condition down the line. So it's really thinking about kind of about the systems and how things work together. And we also know that, when you are experiencing kind of multiple syndemics, those things can have this, snowball effect. So if you are depressed and you are also, using substances, and, you may be more likely to become in contact with someone who has HIV and become infected that way. You may also be more likely to be subject to partner violence. So these things can really intersect and collide in ways that are not good for the individual or for the community. So, and I wanted to see, does this kind of resonate, and so when we think about different communities, different populations that we might work with, does this seem like it is a helpful framework? Does it seem like it lands? And if so, what might we sort of hypothesize as being kind of the intersecting epidemics for other communities? So again, most of the sydemics work was done with gay men living in urban populations, but does that also resonate for Black trans women or young Latina lesbians or other communities of LGBTQ folk, and what might that look like? And then, thinking about, would the specific drivers of syndemic conditions for these communities be different, and how would they be different? And so I just want to leave those as kind of thoughts for you, and we can come back in the question period and talk about that a little bit more. But if anyone has thoughts they want to offer, if you want to chat those in as we move forward, that would be great. I'm going to shift gears a little bit, and we're going to move into our case study scenario. And again, this is drawn from a paper that my colleagues and I published in the American Journal of Public Health a couple of years ago, thinking about networks as sort of a determinant, a sexual network specifically, as a determinant of HIV among young Black MSM. And so I wanted to start this part of this case study with thinking about, there's been a history of scientific violence that's been visited, not just on Black gay and bisexual men, but just on Black folks in general. I think that we talk about, medical mistrust. There are, historical and contemporary examples of how medical and public health systems have not been, not always lived up to their ideals of serving the communities that they're supposed to serve. So we think about things like the Guatemala syphilis experiment. We think about Tuskegee. We think about a lot of these different types of instances where there's been kind of violence visited on these communities. So I say this because there are oftentimes scientific microaggressions that we might be visiting on communities, even though we're trying to do good public health work. And so I think that's just an important thing to say. And then, I wanted to quickly go through some of the epidemiology, but I think a lot of us know this around HIV and where it sits within communities of young Black MSM. And then think about what are some of the limitations of this thinking. I always like to ground my talks within sort of the blessings of our ancestors in some ways. So Joseph Beam was a writer and activist in the 80s and 90s, and wrote a lot about Black gay men and HIV. And so I wanted to just kind of lift up some of his words as we think about kind of what networks look like. So when we talk about kind of this past of scientific violence, so when HIV came on the scene, it was known as the 4-H disease. So the 4-H's at the time were homosexuals, heroin users, hemophiliacs, and Haitians. So there was already this kind of rooting of stigma, and in the earliest conceptions of in conversations about HIV. So back in the 90s and early 2000s, there was this conversation around the down low and how we needed to be able to find kind of this bridge between Black gay and bisexual men and Black women in terms of understanding the epidemic as it was happening in Black women. And so, we didn't necessarily kind of discover that linkage, but that was a large conversation that we don't have to really go into because it's not totally relevant for our conversation today, but it gets us thinking about kind of how people are thinking about networks as a social determinant of HIV risk. And so, I wanted us to think about how do we think about how we have scientific discourse that actually is promotive of health and thinking about how that can ultimately help the young people that you serve in your centers. So again, pretty much everyone knows this data, basically just to say that HIV is very prevalent among young Black MSM, and it's disproportionate to Black MSM's proportion of the American population. And we also know that, when we think about why we see these disparities, it's not because of differences in individual sexual health behavior. So we know that it really has a lot to do with people navigating this HIV care continuum, which has everything to do with the social determinants of health that we've been talking about. So there was a paper that was done by Greg Millett, who was a scientist at CDC, now works for AMFAR, and basically like a lot of his work kind of disproved this notion that the differences that we saw in HIV between Black gay men and white gay men were attributable to differences in an HIV risk behavior. And so, a lot of studies since then have kind of examined, the extent to which MSM partner within racially homogenous clusters and sort of whether people have sex with people of the same race or different races, and how that can be associated with HIV infection. And so that we know that, when we think about this kind of network literature and how that's shaping HIV risk, it's important to think about like what's actually placing kind of these networks, even though these may be a structure, what is actually shaping the contours of that network. And again, that has everything to do with these social determinants of health. So, one of the things that when this kind of conversation was happening, it makes a lot of sense. So, if we look at networks as one of the reasons why we see this disparate rates of infection between Black gay men and white gay men specifically, from an epi standpoint, it makes sense. And to researchers, when you're talking to one another, it makes sense. It also makes sense based on, the fact that we're not seeing these differences in sexual behavior on an individual level. And we've also seen that that's how it works with other types of infectious diseases. So if you have a small kind of interconnected network, the disease is able to spread more efficiently within that smaller interconnected network. Makes sense from an epi standpoint. But I think what we did in sort of this conversation is that we actually assigned kind of pathology like up a level when we go up one level of the social ecologic framework and sort of said that it's not because you individual, Black gay man are somehow deviant, but it's about kind of the fact that you operate in this network that somehow is. And so, so in our assertion is that it's really not sufficient to kind of move that blame. It's about, it's not sufficient to say that like it's your fault for not using condoms, but it's more about the fact that you choose to partner and love people who look like you as a problem. And that's not actionable kind of public health. And I think the other thing that I wanted to say, and I'll move quickly on to the next section, is that health disparities research, not just this type of work, but this conversation has a high use probability of being misconstrued and misused. Because what it does is it conflates sort of the social marginalization that the group experiences as evidence that there's something inherently wrong about the group itself. So when we think about the fact that we have higher rates of suicide, particularly among LGBTQ youth, for example, some people take that to say that that is proof and evidence that there's something actually wrong with LGBTQ youth themselves, and not sort of looking at what is the broader social context that these youth move through that might increase their risk for suicide. And so there's this conflation that there's something that's wrong with the people themselves and not about the context in which they live. And that can be applied to this situation as well. And so again, when we think about, how we talk about this, and our language is so important and so powerful. When we talk about, having sex with other Black MSM as a risk factor, we're stigmatizing those relationships and those networks and those bonds, which we know that community is actually something that is protective for health. And so we have to just be careful with how we use our words in that way. So again, I wanted to just lift this up as a way to think about kind of networks as a way of organizing. And so the key thing that I want you to take home from this is that these networks are not the cause of racial disparities. They are an effect of these other types of patternings that are a result of these broader social determinants of health. So that's kind of how this fits in. And then, there's this whole conversation around, sexual racism that's happening, particularly within LGBT spaces. And so the other thing that comes up is that there's this notion that, the only reason that MSM of the same race particularly MSM of color, are partnering with one another is because they don't have access to white MSM, for example. And it's like, that actually isn't the goal here. Is not to sort of advance in this kind of racial hierarchy that's been created by these networks. And it's also to say that, there are reasons that people may choose to partner with one another that actually are rooted in love and, values that are positive, right? And that these connections are actually valued and can be protective for health. And so I think in the next month's talk, we'll think about how do we leverage these networks that exist as ways to actually facilitate health and not as purely ways to describe risk behavior. So again, thinking about kind of why this is important for the work that you do in school-based health centers. So I think it's important to think about kind of these broader networks. So when you're talking to a young person who's coming in to seek testing or services from you, is thinking about kind of who else is in his network or her network. And so I think it goes back to thinking about, are you screening for transactional and survival sex? I think in one of the case studies that comes up, because that's going to have a profound implication for the young person's risk. Are they having sexual contact with folks who are significantly older than they are? And we know that can be a proxy for childhood sexual abuse, but not always, right? And so, but I think it's important to make sure that you have things in place that capture that really kind of nuanced level of a sexual history, so that you're really thinking about this young person in the context of their networks. So kind of that's why this is an important conversation for the work that we're doing together. All right. I wanted to just stop there for now and just open up the floor for any questions, comments, things that people wanted to lift up, other conversations that people wanted to have. I'm happy to go there now. So thank you for your attention.
Thanks, Justin. Does anyone have any questions or comments? I had a question. So, and I guess I guess it would be best for the clinicians on our faculty. So is Renata on? There you are. Yeah, so some of the screening that you talked about, Justin, screening for co-occurring conditions, childhood sexual abuse, depression, and what you just mentioned about screening for transactional survival sex as well as older partners. Are there validated screening tools that already exist that include those kinds of questions, or is there something else that's out there that providers should be incorporating? So I guess that would be best directed at Renata and Molly as well.
Yeah, so I think some of the, there are child sexual abuse screening questions. They usually fall into the trauma-informed care model. So really screening around past history of trauma, as well as screening around violence, experiences of violence. And I think I have seen fewer measures that are specific to adolescents. I've seen some adult measures around transactional sex as far as a screening tool. You know, besides what we commonly use is just using the HEADS approach to talk about experiences from the individual's perspective as far as experiences of transactional or exchange sex, when speaking about where they're staying, their survival, and not necessarily in the context of activity. But there are specific, as I mentioned, there are specific tools that can be used to screen for trauma and violence, experiences of violence, and that includes sexual violence. So I'll stop there and let Molly jump in if she wants to talk further.
Okay, thanks.
So a few years ago, I was doing some research on trying to better word how I was screening for survival sex, and I found this study. I just put it in the chat. So it was done by Covenant House, which is like a huge adolescent, young adult organization in New York City that has a lot of services for homeless youth, I'm pretty sure is their focus. And I don't know when this study was done. It might have been like, it could be almost 10 years ago now, but they did like a whole thing with like this like law students trying to figure out how to ask questions about kind of sex trafficking questions, well, trafficking questions, including, you know, survival sex. And I found some really helpful wording in that. I don't know if it's validated, but it did change the way that I ask my patients. Mostly what I do is give a little bit more of a lead up to when I'm asking if they're trading sex for anything, and just try to normalize it and say something like, you know, sometimes, you know, when I'm talking to somebody who's in unstable housing and I'm screening to see if they're trading sex, I'll say like, you know, sometimes when we don't have our basic resources and needs met, sometimes we have to do things that we don't like to do and don't want to do and wouldn't do under other circumstances, like trade sex for resources. Have you ever done that? And I think that's kind of what the study gets at. I haven't really seen, like Renata was saying, I haven't really seen a specific validated kind of questionnaire beyond HEADS and beyond ACEs. And I just actually went to a conference about ACEs, and I didn't realize that it's a very helpful questionnaire, but it was developed among a population of mostly white resourced adults through Kaiser Permanente. And it doesn't really capture, because I'm thinking about trying to do a screener consistently at the juvenile detention center that I work at, but I'm finding that things like ACEs don't really capture like community violence. Like I have a lot of patients, or when I'm at the juvenile detention center, I have a lot of patients reporting that they are in stable homes, but it's the violence that they experience in their neighborhoods that has kind of traumatized them, and something like the ACEs doesn't really capture that. And I think that there is a discussion among clinicians and scientists who are trying to have a better screener for childhood trauma to include some of those more nuanced things that aren't captured in the ACEs. So not the best answer, but I would check out that study I linked in. I think it's really fascinating.
Thanks. Anyone else?
I'll ask another question if nobody else has a question. So Justin, I'm wondering if you can speak at all to how to kind of tap into networks of communities that have historically been marginalized from healthcare to kind of bring them into healthcare in a kind of non-violent and productive way.
So I think one of the things that I'm a big advocate of is making sure that, to the extent possible and where possible, that addictions or people that are on the staff kind of mirror who's in the community that you're serving. One of the, worst things is that, like, a lot of times the clinics are offering services and operating communities where none of the staff look like the people that are coming in. And that just visually can create some distance between, the community and the providers. And so I think, one of the best ways that, you can help to earn trust is to actually, hire people on your staff that actually reflect the community that's being served. I know that can be a difficult and not always feasible thing, but I think that is something that folks should aspire to do more, because it does make a huge difference. The other piece of it is really trying to make sure that you build relationships with key community leaders, and I think people always ask, like, what can we do to engage communities, and it takes time, and I think that is something that we as providers have to also be willing to invest, is the time it takes to build these relationships with communities, and to show that we're here to be a resource, we're here to be a partner, but it takes time for that to happen. It doesn't happen overnight. And so so I think two things, get folk on the staff of your clinical organization who reflect the community that you're serving, and invest in the time it takes to really build relationships with these communities, because it isn't going to be something that happens, just because you had like one meeting with a community leader. It's like, it has to be sustained over a long time. And I think that's when we begin to see some of that trust go up. But that does take time to do.
I would agree with everything you just said, Justin, and add also, when you're thinking about who it is that this messaging is going to and coming from, it's more than just the provider. That young people, there is an opportunity for a positive experience for a young person from the moment that they engage with your health center, whether that's a call center staff or a front desk staff person or a security guard. And thinking about all of the folks that work at your health center, I can see and have seen over the time that we've been participating in these echoes that folks are in a group and that they're participating in this together, and then lots of people from your health center are getting this content. And the more we can do that and think about people who entered their role not necessarily thinking that they were passionate about this work or passionate about young people, but they aren't often given any professional development opportunities either. So if we can be thinking about how to share this content back with our health centers, that can go a really long way towards meaningful engagement.
Absolutely. Yeah, and I want to just underscore how important it is for non-clinical staff to also be brought into that conversation, because so much of the experience of young people within health settings the provider can be fabulous and be trained and have kind of all of the information, but if the person that is at the front desk does not kind of greet the young person with kindness, and you've lost that person. And I've seen that happen so often. In one of the clinics where I worked, all of our providers, I would say, were fantastic and had done a lot of work specifically on how to work more effectively with LGBT populations. But our front desk staff didn't. And there was, particularly with our trans clients, pretty much anytime a trans client would come in to, for their appointment with their HIV provider, they would be misgendered by the front desk staff. And that really created a really negative environment for our trans clients, because they didn't, this was the one time in their day they would be reminded of the person that they no longer are. And that can be traumatizing and just make people want to disengage from care. And again, that had nothing to do with the quality of the HIV care they were receiving, but just had to do with that human interaction that they had when they walked into the clinic. And so I want to underscore how important that is too.
Yeah, I think I was just going to say, Justin, I really appreciated your perspective and how you presented intersectionality. I think it's really important to visual as someone who has multiple intersecting identities instead of putting people into one box. And the more you can understand that, then I think the more you're willing to engage with and support youth that may not look like you or that may have different experiences. I think the other thing that I think is really important that I think sites are starting to use, I know we've started to have training or have had training here for our front staff as well, is really around trauma-informed care. Just because a lot of the youth that we see, whether they're LGBT youth or just school health youth or youth from urban or rural communities, it's estimated that 90% of individuals in the world have experienced some sort of trauma, right? So most people have experienced some sort of trauma. And if there's someone who's at the front staff and they don't recognize that the reason why people are rolling their eyes or upset or not responding to questions is because of the trauma they've experienced, and they just are abrupt with them and don't engage with them or misgender them, right? Then that's going to actually bring up a lot more trauma. So really being informed on trauma-informed care is really important. And I think that's something that school health centers and schools can often make sure all their staff are trained on trauma-informed care, because it does touch on a lot of these areas.
Thank you. Anyone else have any more comments for Justin before we pivot to the cases?
Thank you.
All right, thank you, Justin. That was great.